I will discuss with you the corpus callosum, and 6 points will be covered in learning objectives. First of all, we recall the anatomy of the corpus callosum. Will demonstrate the visualization ultrasound. I didn't know if we'll be able to show this on live demo, but since it's recorded, it should be part of a talk on corpus callosum. I think it's important to know some theories on the development of corpus callosum and the implications. I will discuss in detail the typical signs of agenesis in the fetus and some suspicious finding and diagnosis workup and counseling rapidly at the end. The anatomy of the corpus callosum, you should know that it's the largest commissure connecting the cerebral hemisphere, and it's a broad plate of dense myelinated fibers, and it's around 200 to 250 million fibers. And sometimes when I'm asked, is it possible that the baby has no problem with an abscess? That theoretically, yes, but 250 million fibers. In my computer, if one fiber is not working, I have a bigger problem. It's probably a question of time on one hand, but on the other, the brain has such a plasticity that it can also recover, especially in a congenital absence, not comparable with the commissurotomy done after surgery. What we see is actually exactly in the midline, and you see here all the fibers, they are bundled in a way, and this is the plane where we recognize the corpus callosum as a C-shaped body, and you see here from Wikipedia the demonstration of the corpus callosum, how it can be seen. Now, the anatomy and on MR or pathology can be best shown. We have different parts of the corpus callosum: the rostrum, which is the most anterior part, the knee, the body of the corpus callosum, the splenium, and this part is the isthmus, which is very thin. And as you have seen on live demo, the fornix and the septum pellucidum in the child and the adult. In an ultrasound, this is what we see. We see all the signs, but the splenium is not very well developed in mid-gestation, and the isthmus has the same size. But if we proceed until late gestation, this is 36 weeks, you see that the isthmus is getting thinner, and we have the cavum verge then appearing separated from the cavum septi pellucidi, and we see the more developing splenium of the corpus callosum. And as Gianluigi said in his live demo, that once we look at an anterior view to the brain, we can identify the falx, and this hypoechogenic structure is the corpus callosum. At least we can say at this stage there is not a complete absence, and this sign can be called the T sign, and Gustavo may show you some images later on cases where you can see it up to 15 or 16 weeks if you perform transvaginal scan. This is an important hint in an anterior plane. But in general, what we are doing is on an examination where we perform the measurements of the BPD, and we look at the lateral ventricles, and Gianluigi elaborated very well the role of the cavum septi pellucidi, which is the fluid just below the corpus callosum, as one important hint for normality. And we said before, I didn't know that he was going to show this and to demonstrate this, but with a profile through the meteopic suture, the corpus callosum can be well seen, but occasionally you don't see it very well. This is why you should move the transducer a little bit higher and scan through the fontanelle, and then you can see it clearly in a vertex position. You not always need to use 3D and use transvaginal scan for normality. And what we do in everyday's life is what you have seen in live demo. We have a kind of scanning axial, and then we move the transducer, and then we can get a longitudinal view. And this is how it is done from an axial plane to get a longitudinal plane. And we can see for normality the corpus callosum. But occasionally we need a little bit high resolution. And in the last time I was now using this high resolution transducer, and in a bridge presentation, this is what we can see. And I agree it could be more than enough for my purposes, and Bernard Benoit showed us that it's possible. Or if it's in vertex presentation, then you go transvaginally to demonstrate the corpus callosum. And some will turn or rotate the baby until they get it into vertex presentation to get the corpus callosum demonstrated in a high resolution. And as we have heard before and published in the paper of Gianluigi, we can acquire a volume, and Bernard showed us also this on the live demonstration, and rotate and adjust the lines until we get the shape of the corpus callosum and the cover of it. Now, the color Doppler or sensitive power Doppler can be used to demonstrate the kind of shape of the corpus callosum, and in abnormality we may see some abnormal vessels, but for complete absence it may be helpful, but especially in cases of dysplastic and dysgenesis, it can be tricky to recognize normal from abnormal. This is why I'm, in the meantime, very careful making a normality only because the color Doppler is nice to be seen, which is not very true all the time. When can we start to see the corpus callosum? Actually, it develops between 8 and 20 weeks gestation, but we start seeing it between after 15 weeks, 16 weeks, when we start seeing the cavum septi pellucidity. In a way, it is an indirect. In general, it's at the time when we perform amniocentesis. In female or in girls, you see it a little bit earlier than in boys. In general, 15 weeks plus, and in boys, 16 weeks plus. And longitudinally, we don't see these details before 18, 19 weeks. And with color Doppler, even without seeing here the corpus callosum, we may identify the presence of something where the pericallosal artery is crossing over. Now, we should discuss few points on the development of corpus callosum. It is a late event in ontogenesis, and this is why you see the close relationship to the optic chiasm, to the anterior commissure, and by magnifying this image, you see that it is developing together with the septum pellucidum. And since they develop together, you will always expect that you have to see the septum pellucidum to assume there is a normality of the corpus callosum, and vice versa could be also true or important. And the classical rule is the so-called front-to-back rule. That means the development occurs from front and then going backward until the splenium part, and this is why in typical cases of partial agenesis of corpus callosum, you'll see often that the genu and the anterior part of the body are present, but not the posterior part. And you see here the third ventricle, which is elevated and seen then in the level of the lateral ventricles. But this is not the complete truth. I will say it's a recent theory because in all the brain development stuff, all these things happen a little bit slowly, which is still an actual 196 published by Kier and Truvit. They showed on anatomic and MR and embryologic specimen that it's a kind of bidirectional development. And they assume that the corpus callosum develops first in the region of the future anterior body and grows in both directions. In other words, this is what they were showing, that this is what can be seen, and by drawing this line along the anterior commissure, you can see it develops in both directions. And this is from their paper cases from 14 weeks, where you identify the corpus callosum but not the anterior part, and then developing into both directions until the end of gestation. Why is this important? Because it can also occur that you assume you have a normal corpus callosum, but by observing it closely, you see that this part, the genu and the rostrum are missing, and this part, the rostrum, is missing. And this is quite, even it looks nice, but it could be quite severe, because this is the region where you may assume that optic nerve may be involved, or even holoprosencephaly. And this is why we should know that it's not only behind the anterior body where we assume that something is lacking, but it could be also in this region, and this could support also the theory of bidirectional rather than front-to-back rule. Now, what is the anagenesis of corpus callosum? This is something where Many of you will know already, but actually the most difficult in diagnosing the complete agenesis are the first 3-4 cases. Once you have done the diagnosis several times, then it's quite easy. You put it to the transducer and you see it if it's complete absent. Then the challenge is going to be the partial agenesis. And you see here, as Gianluigi was saying this morning, it's quite common. And you are right, Gianluigi, we have in our unit more cases where agenesis or hypogenesis of corpus callosum than spina bifida. And we have seen in the last 8 years more than 60 cases, but by far less spina bifida cases. And I guess the more we know about this disease and the more we are able to see it. In general, we'll have one direct sign, but many indirect signs, and we have to rely on the indirect signs. The direct sign would be, of course, trying to get the mid-sagittal view to see that the corpus callosum is there, but it's difficult to demonstrate something which is absent. And this dilated third ventricle should be not misunderstood as the cavum under the corpus callosum, and this is why this is typical image of a second trimester corpus callosum agenesis. You don't see so really what you are looking for, but we have to be careful to make the final diagnosis under this image. This is why we rely primarily on axial planes, and the typical images on axial plane is first of all the absence of the cavum septi pellucidi, and this is what is typical in at all gestation age from the 18-19 weeks gestation, and in addition the dilated interhemispheric fissure. And this is on a video clip how it looks like, and you see here, first of all, you don't see cavum septi, and you see here the so-called the too many lines. You see the two layers of the anterior horns and the dilated interhemispheric fissure and the falx cerebri as well. This is such a typical image that once you have seen it, you will never forget, and next time you make the diagnosis straightforward. If we discuss the agenesis of corpus callosum, you should know what are the bundles of Probst, not because he's coming from Vienna where Daniela is coming and she will show us this later on. Under normal conditions, you have the neurons crossing the midline to build the corpus callosum, but in cases where there's an absence, these neurons do not cross, but they arrive to the middle and they go in parallel to the midline to the posterior part. This parallel, and this is a huge quantity of neurons, were detected by or described by Probst, and these are the typical thick axons which let the anterior part being compressed. And this is here on an example from a paper on tractography, the normal corpus callosum, and you see here along the midline the Probst bundle very well demonstrated on this example of tractography. Now, if you compare the agenesis of corpus callosum with the normal finding, what you see here are the typical signs on the ventricular system in the axial plane. Under normal condition, you have an anterior horn where you can even measure it, and you have the posterior horn. But if you have a typical agenesis of corpus callosum, this here is the region where these neurons are crossing, and they are so tight that they are able to compress the anterior horn. Posteriorly, the cortex is not so tight, and this is why there is almost always a kind of dilation, and this is called colpocephaly. And this is a typical sign, what you see in corpus callosum agenesis, that you have the compressed anterior horn and dilated posterior horn. And there is a sign which is easy to know, which is the teardrop sign. The teardrop sign means that the shape of the lateral ventricle reminds you of a teardrop. I think it's better to understand than colpocephaly. And this is the typical image. If you see it once, you will never forget. Additionally, occasionally, you may see also a dilated and cranially shifted third ventricle. And you see in this fetus, there was an addition, as Gianluigi was saying, once you have an absence of septum pellucidum, even if you are stuck to the agenesis corpus callosum, you see here a kind of schizencephaly. The dilated third ventricle and shifted is present occasionally, but especially in later gestation, it may be more obvious. Now, you see here a classical example. You see the teardrop sign, this typical shape of the ventricle, the compressed and lateralized anterior ventricles. We have the too many lines of the dilated interhemispheric fissure, and we don't see here clearly the dilated third ventricle. Now, what are the other plain signs? In in the coronal plane, the typical image is like this one. And you see these red dots are the Probst bundle, and this is why you see that they are really pushing the anterior ventricle. And the shape of the ventricular system in the anterior view there are different descriptions, but the classical one is called the Steer-Horn sign, and the Steer-Horn sign is so typical for coronal view of Agenus corpus callosum that you can recognize it on CT, on MR, and on ultrasound as well. And you remember the T sign on the normal conditions and the Steer-Horn for the agenesis of corpus callosum. I don't show you the best example of transvaginal, but I show you the transabdominal scan. Once you rotate the transducer to get a coronal view, that you see that you don't have this T, you have rather this image of the Steer-Horn, which is well recognizable. Now, for color Doppler, as I told you before, you can use it if you have already or nearly the diagnosis done, and you don't see a pericallosal artery. You see the anterior artery having some abnormal pattern, and you don't see the structure under the anterior. There is no pericallosal artery per se. We heard this morning that the gyrus singuli can be recognized, but not before an ultrasound before 26 weeks, and this is what we see at around 30 weeks gestation. Over the corpus callosum, there is this gyrus singuli, which is the typical structure defining also the corpus callosum in a way. And in cases of agenesis corpus callosum, this is absent, and we have a radial course of the medial sulci. And this image is so typical, and it has also a sign. This sign is called in some groups the punk sign for the younger generation. For the classical generation, it's called the sun ray or the sunburst sign, because this radial array is so typical. And this is what we can see on later gestation, on transvaginal or transabdominal ultrasound. You see here the gyration of the brain with the lack of the gyrus singuli, and you see here the dilated third ventricle. This is the sunburst sign. So in how early can we diagnose this? According to Malinger, in hands of expert, probably 14, 15 weeks, and there was a suggestion by Lachman and Nicolaides that in first early gestation, the midbrain may be elevated and the falx may be shortened. This could be an interesting observation. We have to get some more prospective observation of it, but interesting finding to look forward, especially in high-risk groups. Now, under MR, it is for MR people a straightforward diagnosis because you see the absence of connection, you see the compressed horns, you see the bilateral teardrop sign, you see the Steer-Horn sign, but nevertheless, it's still difficult in the mid-sagittal plane to describe if it's here something missing or not, and Daniela showed us how important it is to have a good presetting. But for us, MR has two, in my opinion, two important roles. The first one to confirm what you are suspecting, and the second one to watch what's happening at the level of the cortex of the brain and the other areas. Now, why is agenesis of corpus callosum missed? I think in almost many cases because the signs are not known, but sometimes because the lateral ventricle are not dilated, and this is why they may be missed, because the third ventricle may be malinterpreted as cavum septi pellucidi, or as we have seen before, the columns of the fornix may be malinterpreted as cavum septi pellucidi, or some cases have a cavum septum pellucidum, some fluid, and especially in partial agenesis, and this is why it's not detected. And if you compare the cases you have and we have by far more complete absence, and rather occasionally some case of abnormal shape and partial agenesis. And according to Pargovich in his book, he says they have, of course, by far more partial agenesis and rarely complete genesis, because these are the syndromic cases, and they see more cases which, let's see, who escape our detection on antenatal ultrasound. These are the hints why it's difficult to detect, because in this case, I'm sure many years ago, no one was looking to this brain as abnormal because there were no dilation of the ventricles and no hint. In this case, some people were maybe looking for the dilation and make the whole setup of hydrocephaly on ventriculomegaly and misinterpreting this as cavum septi pellucidi, but it's more in the middle where the other one is more anterior, and you don't see the anterior horn, which should be seen. And as Gianluigi was saying, I didn't know that he will show this. I had in my talk also the fornix of the columns of the fornix can be mistaken, but you have heard about the 3 lines. And here again, an explanation of this. These are the columns on the fornix which are here, and this is the corpus callosum. And if we get, and this was described in a paper in Journal of Ultrasound Medicine a couple of years ago, if you cut at this higher level, you see the anterior horns with the septum pellucidum lamina, and if you go a little bit lower, you don't see the anterior horns as you have the typical 3 lines. This is why what you have to be aware of, and this is what we have seen on a live demonstration as well. And you see here on a video clip how we can move from the true cavum septi to the columns of the fornix. Now, what is a normal corpus callosum? Normal corpus callosum should, actually, if you want to have a targeted examination, to have the normal segment should be recognized. It has to get a length within the normal range, a thickness within the normal range, and it shouldn't have additional signs as abnormal anterior horns, abnormal cavum septi, or at the interhemispheric fissure. And this is why, if you see what is the length, what is the normal length, at 18 weeks, 15 millimeters, at 20 weeks, 23 millimeters. There is a table by Reuven Achiron. I put it on the CD for you. And you see, as we heard before, that at 22 weeks, we have already 1-to-1 to gestational age, the 22 millimeters, and then a little bit later on. We have also data on the thickness, but we have to be careful on deducting from 0 point some measurement on outcome and prognosis of these children. But roughly speaking, we have at 22 weeks, which is the time where we are scanning often patient, the 2 millimeter. And in one study, it seems that girls, they have a little bit thicker corpus callosum than boys. In general, 2.1 for girl, 1.9 for boys. But you can do your own observation. And you see late in gestation, we are between 2 and 3 millimeters. But let's say, in roughly speaking, you should know that at 22 weeks, we have the length of 22 millimeter and the thickness of 2.2 millimeter, and this is the normality. And as Benoit said before, after 22 weeks, the length is in general longer than the age in gestation. Don't start doing diagnosis at 19 weeks because it's really not reliable. And don't overestimate a value which is 0.1 millimeter less than the value. There is no data saying that there is a correlation between this, let's say, borderline sizes and abnormality. Now, what is about the hypogenesis and dysplasia? The detection is actually very difficult, and you need really to have experience in detecting complete agenesis of corpus callosum. In my experience, I never had detected an abnormal corpus callosum by a normal axial plane, only by getting to this plane and checking the length or the thickness. In general, you have always some additional things you don't like on the axial view, but you need to have experience on detecting complete agenesis. Fluid may be in the cavum septi pellucidum. This is not so reliable, I assumed at the beginning, but it looks in general unusual. You have commonly compressed anterior horns, and very common this typical image of the dilated interhemispheric fissure, which is very common in these cases, but not the fluid in the cavum septi pellucidum. This is why you have in general some signs suggesting neurosonogram. Even a Blake spot cyst can be a hint, or other syndrome. Now, I show you 4 examples, or had an abnormal corpus callosum, but you see here in this one it was suspicious brachycephaly. In this one we had a septum within the septum pellucidum. This is not typical normal cavum septi, and you see already the teardrop sign, and this one also is an abnormal horn. This is why we have to be careful, but then we need to get the additional planes. And you see here, if you rely only on the cavum septi pellucidum, we see that there is some fluid, but in the higher plane, we see the compressed anterior horn, we see the teardrop, and we see the so-called many line, the dilated interhemispheric fissure. This is why the first hint for complete agenesis may be the abscess of septum pellucidum, but you need also to consider the other signs which can be present in partial and in complete as well. I show you 4 examples, and these are bizarre looking. This one is definitely very short, hypoplastic, 15, 16 millimeter for, it was the same size at 22 weeks, the same size at 24 weeks, and this dysplastic. This one is very thin in this part. This one is very thick, and this one is a partial agenesis. I could show you additional one. I want to show you only that these are abnormal, but we don't know the prognosis. And this is why we should get additional information from the fetus, from MR, and so on. And we have also to be careful because we don't know what is the outcome of all these people. And this is why how long and thick was their corpus callosum at 25 weeks? No one knows. Sometimes you may decide to have this and that person. You don't know how they were in utero. And this is why you should give a chance for some slight other-looking persons or people. So I come now to the part which could be interesting, which is counseling. We had just in the White Journal an article on this topic, which is also on the CD. I will not cover it in extensive, but in general, you can say following. First of all, which is obvious, if you have severe additional malformations, the prognosis is severe. If you have so-called isolated, even if you are the best, you have done normal MR and so on, you still have to tell the mothers 10 to 20% of the cases, 15% is acceptable value, will be part of a syndrome postnatally. You cannot rule out prenatally. The so-called isolated cases will be neurological, normal, or borderline at 3 to 6 years of age. And this is a very important message. Please listen carefully to it. It seems that there is no difference between complete and partial agenesis. I have very often a second opinion saying, but I'm sure there are at least some fibers and so on. There are even data showing that the partial agenesis are rather the group syndromic. And it's not enough to have some fibers crossing over to say, well, it could have some good impact. This is why it does not play a big role to have a complete or partial, probably better to have a complete without anything else. Now, another approach, I like it very much, I copied word by word, was in the book of Barkovich and Ribot, the one you heard before this morning, who went to southern France and wrote this article. They have the best book on pediatric neuroimaging, and they say that although it is reported that isolated callosum agenesis may be asymptomatic, in the experience of most neurologists and neuroradiologists, accidental finding is really very rare. In general, and this is what you should know because these are the symptoms parents should be confronted with. In general, patients will present to the neuroradiologist and neurologist with seizure, microcephaly, delayed development, mental retardation, or hypothalamic dysfunction. In case they have a normal cognitive and neurologic development, they have behavioral and neuropsychiatric problems leading to learning difficulties, language and social communication disorders, and visuospatial attention deficit. In other words, there are some direct problems at the beginning of life, like seizure, but some even later in development. And this is what we should know, and this is but what we cannot predict which case and which child is going to develop this way or that way. This is why once we diagnose an agenesis corpus callosum, what we do is, of course, to rule out additional cardiac, extracranial malformations. We should rule out chromosomal anomalies, trisomy 18, 21, and other inversion may be observed. And at the level of the brain, we should check for Dandy Walker, for schizencephaly, for the presence of any cyst, for the presence of lipoma detected rather in later gestation, and polymicrogyria and heterotopia. And we should perform MR to confirm the diagnosis, and in addition to rule out many of these things. Even if we do it at 22 weeks, we should repeat it at 30 weeks if the parents are willing to continue pregnancy. Now, show you some few examples. This is agenesis corpus callosum with a Dandy Walker malformation, straightforward diagnosis. This is with schizencephaly, one example you have seen before. I'm always afraid of this finding because if it was really hiding behind this, I may have missed this condition. Lipoma is rather diagnosis for third trimester. And this one is a challenging one, the presence of additional interhemispheric cyst or some cortex involvement. You see here the cortex and some abnormality at the level of the anterior part. And an example, this one was isolated. We didn't find anything else, but it has problem after birth with seizures, and after 1 year it was pyruvate dehydrogenase deficiency known to be associated with the ACC. And this child was detected just 1 day before delivery And at 3 months, it had cardiac problems. It had then cardiomyopathy, got a cardiac transplant, and it has a severe handicap with an unknown syndrome. And we had a recurrence 2 years later. That means it is something recessive we don't know about. And if you look at what Rebaud said in his book, they said that they have done an online search in Medline and OMIM, and they found 187 syndromes. 187. You can work your whole life and don't see all. But they said one of the most common described is the Aicardi syndrome. And I want to finish my talk by describing this sign as a new message for you. What is Aicardi syndrome? Actually, it was in the past classically the triad of dysgenesis, that means agenesis or partial agenesis, plus chorionatal lacunae seen only by ophthalmologists after birth, and spasm, infantile spasm. Seizure, development delay, and actually it's a severe handicap. It is only observed in girls because male may be or are lethal. And until now, we don't have a gene localized, but I think it's a question of time where we have the gene. This is why I remember we had one case when I was at the Charité Hospital. We had a genesis and here an orbital problem, and it has a vertebral problem, and we assumed it could be Aicardi syndrome. But in the meantime, there is a new definition, an extended one, which is updated. Now there are modified criteria, 2 classic features, and at least 2 other major or supportive features which may be suspicious for the Aicardi syndrome. The classical one and the major additional one are cortical malformation, mostly polymicrogyria, periventricular heterotopia, we'll hear about it later on, the presence of cysts around the third ventricle or choroid plexus cyst, optic disc nerve coloboma hypoplasia, and you see now the link back to the chiasm and to the optic nerve sheet. And we have supportive additional things like vertebral abnormalities, microphthalmia, split brain, and so on. I put together what I assume for my workup, what could be important in prenatal suspicion. If I see a partial or complete agenesis in a female fetus, I will check the eyes to rule out coloboma, optic disc hypoplasia, and microphthalmia. I will check for any cyst like choroid plexus cyst, and especially the interhemispheric cyst or the cyst near the third ventricle. And in some articles, you will find always the combination of agenesis, corpus callosum, and these kind of cysts are as typical sign of Aicardi syndrome. Polymicrogyria, you look at the gyration of the brain, and if there is any hemispheric asymmetry, and corstovertebral anomalies. I'll show you a case. This case with agenesis, you see this cyst. In the past, we say, oh, a cyst does not play a role, and a plexus cyst, of course, it plays a role, because now we know that this combination could be a typical sign of Aicardi syndrome. And I had a case exactly a year ago. It was in January with a large cyst in the brain. We diagnosed as interhemispheric cyst, knowing that this cyst can be part of a problem with the corpus callosum. We're able to see that there is dysplastic, short, and thickened corpus callosum. And then if you go to the list, you know that you have to check for the cortex, and this is then how you look to the brain, and you see these signs. I'm sure on a routine scan, I will never look to this brain at this part. And I moved to the right side, and the right side, you saw this other side. This is, for me, the first side of polymicrogyria. I sent the case also to Gustavo, and he said, yeah, the same, and we've done MR. Thank for the colleagues here in Berlin working with us, and we could confirm this typical sign. This is clinically, for me, it has already 3-4 signs of Aicardi syndrome, but even if I don't call it Aicardi, already the presence of abnormalities at the level of the cortex are very suspicious. So I come to the end of my talk. I showed you many signs, and this is why I decided today to give you take-home message as signs. First one, the first image we look for is the axial view of the brain, where we see the cavum septipellucidi. I showed you the T sign when you look at the coronal plane, and I showed you that in a mid-sagittal plane, the C shape of a corpus callosum can be well recognized. Because you are in Berlin, you see here in hieroglyphics, this is the letter ACC, which is agenesis corpus callosum. What you see in agenesis corpus callosum, there is no cavum septipellucidi, there is the teardrop sign, there is the many lines, and there is a steer horn sign. We have seen, in addition, the sunburst sign later in gestation. Furthermore, I hope to convince you that transvaginal ultrasound, in combination with or without the 3D, can be of big help. It is mandatory today to perform MR on these fetuses, but you need a good colleague to know how to work. But I showed you the big challenge we have was always to detect, on one hand, the partial agenesis, and on the hand, to counsel all these parents. And this is the sign of it, that it's very difficult to make the diagnosis and to give counseling. But let's say the typical answer you can give in every counseling is we don't know what's going on. If you missed something, you can go on the website of EasyWalk and have this recorded. And I thank you at the end for the attention. And thank you for coming to Berlin.